Well, hello and welcome to this Forum Live webinar, which is on the treatment of IMIDs with JAK inhibitors. And it's a real pleasure to have you join us here today. And I'll go through in a moment and introduce the faculty who are with me to talk to you. But it's also really interesting and nice to look at a number of different diseases with a single type of treatment and to see what we learn from the differences between them. Okay, so here's the faculty. So my name's Chris Edwards. I'm a rheumatologist in Southampton in the UK. And we're joined by Professor Arthur Cavanaugh, who is in San Diego. Hi, Artie, thank you for joining us. Who's going to talk about treatment of psoriatic arthritis with JAK inhibitors. And also Ed Vital, who's a professor in Leeds in the UK. And Ed's going to talk about treatment of lupus with JAK inhibitors. So we've got three diseases, all at different stages of their relationship with JAK inhibitors, and different amounts of data and different amounts of thoughts for the future. So keep your questions coming in so that we can pose these. Disclosures, here are our disclosures. Just pause on those for a moment. And then just the housekeeping slide. So to ask questions, and we'd really love your questions because the discussion between us and yourselves is the thing that always makes these sorts of webinars so interesting. So you can see on the bottom, you can use the Q&A tab to press on that, and that it will allow you to ask questions that will come through to us. Please don't use the chat function. We won't be monitoring that. So use the Q&A and send them in at any stage throughout the talks that we'll be delivering. Okay, so here's the running order. So I will kick off in a moment with rheumatoid arthritis in relation to JAK inhibitors. And I guess we've probably got the most data and most established use of therapy there. Then we'll have a bit of a Q&A and discussion about that. Then treatment of psoriatic arthritis with JAK inhibitors, fair amount of data and some clinical use increasing now from Arthur Cavanaugh. And then another Q&A and the discussion, and then on to Ed Vital talking about lupus, where I guess there's less direct knowledge, but lots of sort of theory and lots of interesting things to look at. And then we'll close with a discussion and then a final summary. Okay, so I'm going to kick off and I'm going to talk about rheumatoid arthritis. And I just thought I would set the scene with this particular slide, which reminds me of being a research fellow at the Kennedy Institute in the sort of late 1990s and being asked questions by visiting professors who were doing sabbaticals in the Kennedy Institute about why are different sorts of inflammatory disease different, what bits are the same, why, for example, is there erosion in one disease and bone formation in another, and in spondyloarthropathies both. And why then in CTDs do you tend not to get so many erosions? And if you see calcification, it tends to be in soft tissues. So with this knowledge, we can see that there are differences and there are similarities between the diseases that we look after. And with this in mind, we can move on to thinking about the JAK inhibitors. So these are the 4 JAK inhibitors that are licensed in Europe, slightly different licensing within different countries around the world. But you can see, so all of the JAK inhibitors licensed in Europe for rheumatoid arthritis, 2 tofacitinib and upadacitinib for psoriatic arthritis, 1 for axial spondyloarthropathy, upadacitinib, 1 for ulcerative colitis, tofacitinib, and 1 for atopic dermatitis, baricitinib. So let's focus a bit more on rheumatoid arthritis. So rheumatoid, of course, is an inflammatory disease of joints, but systemic inflammation also does other things. It's associated with extra-articular features. It drives comorbidities such as early cardiovascular disease. And then from the patient perspective, the whole experience of rheumatoid is more than that. It's also the mental health problems that are associated, the patient-reported outcomes, particularly pain and fatigue, and effects on other things such as cognitive function as well, which is a particular interest of mine in relation to rheumatoid. So let's introduce JAK inhibitors a little bit more, and you'll have seen slides like this a lot, so I don't want to labour the point too much, but it's really just to raise the fact that these are clearly different mechanisms when we're blocking JAKs than when we're using a biological therapy to block a cytokine or to deplete a cell. In the case of the biologic, we're binding very, very hard, usually with an antibody to one particular cytokine and trying to get rid of it as much as possible. And with a signaling molecule inhibitor, we're trying to dial down often several different cytokines and growth factors, and you can see them listed along the top of this particular cartoon. The effects of that then are listed along the bottom, and various effects on inflammatory cells, hematopoietic cells, and other cells. And from the particular actions and particular JAKs that are blocked by individual JAK inhibitors, you could make some predictions about which cytokines will be inhibited and what effect that will have on the disease. For example, here's IL-6 towards the left-hand side, and we know blocking IL-6 tends to reduce inflammation associated with rheumatoid arthritis. And then on the right, we've got interferons, which we might think, okay, maybe we can predict the adverse event that's been seen with herpes zoster being a bit more common. But also in relation to Ed's talk, maybe we might think that JAK inhibitors might have efficacy in lupus, where interferons and an interferon signature is important. So here's a slide with a table to differentiate the JAK inhibitors a little bit more. So slightly different dosing. Differences in JAK specificity. Now, that's a subject for another Foreign Live meeting, I think next month, with John Isaacs, looking at JAK specificity. But you can see, certainly in the summary of product characteristics, this is how they describe it, degrees of JAK specificity. So baricitinib on the top 1 and 2, more than 3, and much more than TYK2, for example. They all have short half-lives. Excretion is different for the different molecules. So baricitinib and filgotinib is more excreted through urine, tofacitinib more metabolized through the liver, and upadacitinib a bit of a mixture. Okay, so let's think about efficacy studies of JAK inhibitors in rheumatoid arthritis. And this slide shows the phase 3 trial programs for the 4 JAK inhibitors that I've mentioned. You can see those lined up along the top. And then on the left-hand side, we can see the different populations that the different trials have been tried within. So treatment naive on the top, methotrexate inadequate responder as we work down, and then the most hardcore biologic DMARD inadequate responders on the bottom. And you can see there are a number of different trials that are similar across similar populations across the different JAKs. And in particular, there are 4 studies, 1 for each of the JAK inhibitors, which have been head-to-heads against adalimumab. And those, for me, those have been pretty exciting trials to look at and to see, because we're using anti-TNF therapies as very much our first treatment for severe rheumatoid, with lots of good efficacy. Bottom right, just to draw your attention to, there's another head-to-head of upadacitinib against abatacept in the biological DMARD inadequate responder group. So a little bit more information from that. Okay, so I'm not going to show you loads and loads of data slides, because I think for rheumatoid, you've probably seen a lot of that, and it will be interesting perhaps to see more of that in relation to psoriatic arthritis. But here are the 4 studies: oral strategy for tofacitinib, baricitinib, RA-beam, select compare for upadacitinib, and filgotinib, of course, the Finch studies. The primary endpoints have tended to be ACRs of various. Usually it's been ACR 20 at 12 weeks, but you can see for upadacitinib, there's a slight change, isn't there? Because ACR 20 was the primary endpoint for the FDA requirements. And the European Medicines Agency said, hey, rheumatologists, you've been going on about remission for so long. We'd like that as a primary endpoint. So there was a co-primary there. There's different statistics that's been done, non-inferiority and superiority outcomes you can see listed on the bottom of that particular table. And I think the thing to say is that all of the JAK inhibitors are pretty effective when you compare them to adalimumab. They're at least as good, and for some of the stats that's been predetermined, there's been superiority shown for certain endpoints as well. And the sort of things you see, so for example, baricitinib RO-beam, at the primary endpoint, you get about 70% of people achieving ACR 20. And for upadacitinib select compare, you get about 30% of patients at week 12 achieving the remission criteria of DAS28. Okay, so I mentioned the patient experience, and this slide is just to remind us about all of the other things that systemic inflammation does, and how it has effects on the brain as well, and how both those effects and other effects lead to the pain experience and the fatigue experience for patients. And I think when thinking about efficacy of JAK inhibitors in rheumatoid, there is a bit of a story around a particularly good effect on pain, which from some of the published data would suggest that's more than just an effect on reducing inflammation. It seems to also be some sort of direct effect on the pain process, whether central or peripheral, so something to bear in mind. Okay, so I'm going to spend a little bit of time on safety. And I think One of the important things with safety discussions is always to think that this is a risk-benefit balance, and it depends in the context in which you practice, the population that you look after. But uncontrolled rheumatoid has some pretty big risks. It drives comorbidities such as cardiovascular disease, it increases the risk of infection all on its own. And actually some of the data that has come out around COVID and poor outcomes related to COVID shows that if you have uncontrolled inflammatory rheumatic diseases, you tend to do worse, even before you add in the immunosuppressive drugs. So controlling rheumatoid is important in reducing many of these risks. On the bottom, there are things we're always concerned about. So if we're using immunomodulatory therapies, then infections are things we look out for. And we went through working out how to live with the TB risk in relation to anti-TNF. Herpes zoster is a signal with the JAK inhibitors. And now we're looking at malignancy. Takes a little bit longer for us to be confident about because of the longer lag time between exposure, perhaps. So we're going to watch that over time. And then cardiovascular. And there are a few things to say here, and I'm going to show a couple of slides. So just thinking about MACE, so major cardiovascular events, and also thromboembolic events. So where does the clotting risk concern come from? So it comes from a couple of different sources. From the baricitinib trial program, there was a bit of imbalance between placebo and the 4 milligram dose of baricitinib, showing a little bit more VTE type events. Doesn't seem to have continued to increase over time. There doesn't seem to be any more worrying signal than that, but that raised it as an issue. And then the other thing that's come up is the oral surveillance type data in relation to tofacitinib, and I'm going to show you a little bit of that. This is just to put it all in context. Inflammation makes thromboembolic events more likely, and this really nice Swedish data shows that if your DAS28 is higher, you are more likely, if you're a patient with rheumatoid, to have more thromboembolic events. And these are like the slides we saw for lymphoma risk in relation to TNF. It was disease activity that was driving the risk of lymphoma rather than anti-TNF. And perhaps, perhaps there's something similar in relation to some of the VTE data. Okay, so here's oral surveillance. I certainly haven't seen all of the data. I don't think it's been shown, but this was from the press release. So what's oral surveillance? So this was a safety study that was done to look at tofacitinib. It was done in a particular population of individuals with rheumatoid who were 50 years of age or older, and they were enriched for having had at least one additional cardiovascular risk factor. So it's a particular population. More than 4,000 patients, and they were followed to look at a co-primary endpoint of the numbers of individuals having major cardiovascular events, MACE events, and for malignancy as well, and followed over time. And I'm sure you would have seen some of this data. So, what did it show? Well, it seemed to show that there was a greater risk with both the doses of the tofacitinib, but particularly for the 10 milligram dose associated with the tofacitinib use in relation to having those MACE or malignancy events when compared to the TNF inhibitor. And that's raised some concern. And I think we have to see the full information and try and decide exactly what this means over time. One of the things that's important to note is this is tofacitinib versus TNF inhibitor, not versus placebo or not versus a CS-DMARD. So what we can't tell from this is whether there's any increase in the likelihood of these events as a result of tofacitinib, or whether it just doesn't decrease these events as much as the TNF inhibitor does. So more thought required. And we'll see over time, I guess, whether this is tofacitinib specific or whether this might be related to the other JAK inhibitors. So maybe there are questions around this you'd like to send in. Last thing about efficacy, just positioning. So EULAR, other major international organizations have looked at the systematic reviews and said, look, the efficacy and risk put together makes us think JAK inhibitors can be put at the same level in the treatment pathway as biological DMARDs. There's more information saying you maintain efficacy if you switch between different JAK inhibitors, and switching is commonly being done. More information was at EULAR about that. And then there's a little bit of information to suggest that discontinuation seems to favor JAK inhibitors over TNF inhibitors, bits from the BSR Biologics Registry, bits from the Swiss Registry, and also from the JAKpot study. But I guess we've also got to be slightly careful because the patients that have gone on to JAK inhibitors have often been further down the pathway. And if you're further down the pathway, perhaps it's harder to discontinue because there's less other drugs to go to. But, an interesting observation nonetheless. Okay, so that's my last slide. So here's a summary. So JAK inhibitors in the context of rheumatoid have a pretty good efficacy and I think overall acceptable safety profile. We're still watching the VTE MACE story to try and understand exactly how we manage that. There are important effects on pain and we're gaining real world experience. Okay, so discussion time.
Hey, Chris, let me jump in. A brilliant presentation. That safety issue, as you said, is really very, very much in everyone's mind. In the U.S., we're a little bit on hold. The FDA is not yet come out with a position as based on oral surveillance, but looking across the pond, the EMA had a pretty strong statement about tofacitinib, and I'd be interested how that's impacted you all in your clinic and how you talk with patients. And is it all the JAK inhibitors, or is it just with tofa that the discussion has been changed?
Yeah, I think those are difficult discussions, aren't they? So tofacitinib has been used much less in the UK. So we have just far less experience. So the license came much later. So our experience is much more in baricitinib and now upadacitinib. So that's really influenced how it impacts us. So in a way, we've been able to sort of put that to one side and go, maybe that's tofacitinib. We're not so sure about the other JAK inhibitors. But certainly when I speak at meetings, other webinars, and you hear views from physicians, not just in other European countries, but around other parts of the world, it's a real concern. And in some countries, they would link it and say, how do you know it's not all of the JAK inhibitors that are doing this? I suppose the bit that I just wonder about, the bit of information I'd really like to know, you'd really like that study with a placebo group or a CS-DMARD group, because I'd like to know if is the JAK inhibitor increasing that risk, or is it just not as good at decreasing it? Because we know TNF inhibitors will decrease the risk of certainly of MACE events.
There's a question come up in the chat, Chris, from Dr. Neeraj Jain in Delhi in India, asking about latent TB, which of course I remember being such an issue when we first started anti-TNF, and now it has to sort of be thought about all over again, I suppose. He specifically asks about patients with a positive MON2 test, but not other evidence of TB, although of course we may use other tests as well, I guess, as well.
Yeah. So I mean, personally, I treat the JAK inhibitors in the same way I do the anti-TNFs. I screen in the same sort of way. So for us, that would usually be a quantiferon test and a chest X-ray, put in the context of the sort of exposure profile of the individual patient that we're looking at. And with these people, I tend to ask the chest physicians, and I feel more comfortable. Often, if they think there's latent TB, they're going to give them some degree of anti-TB therapy, whether that's just a single agent for a longer period of time or multiple agents for a very short time. So I tend to treat it in the same way as the TNF inhibitors. I don't know, do you do the same, or Artie, do you do a different thing?
Well, I think they all share the package warnings about TB, but to me, TB is really a TNF thing, more so than any of our other agents. So I do what you said, and I do that. But I also worry much more about the zoster, and that's become, I think, sort of a unique conversation with the JAK inhibitors. And wherever possible, since we have now the killed vaccine, which is very acceptable, that's become a standard with the JAK inhibitors more than with other agents. Although we certainly saw shingles before with our other biologics.
So how do you use the vaccine in relation to the JAK? Do you do it before you start the JAK inhibitor? Do you wait 3 weeks? What's the strategy?
I try to do it before. The patients have to go get the vaccine. We don't stock it in our clinic, so they can actually just go to a pharmacy and get it. One of a difficulty, oddly, is that it's approved for older persons. So if you have a younger patient with rheumatoid, they may have to pay for it out of their pocket, which would be a couple $100. But I think it's totally worth it. I tell patients, I don't have a lot of people with shingles, but I can tell you their names because it impacted their life so much, and it can be such a negative impact on their quality of life.
Mm-hmm. Is there another question there, I think?
I suppose while we're talking about safety, the other issue is that we keep thinking about is DVTs, which is, we're not using JAK inhibitors very much in lupus yet, although there are a few patients with overlaps and so on. But of course, thromboembolic risk can be a much bigger issue. And I know from the trials that that's actually caused us a lot to think about, really, isn't it?
Yeah. So I guess that brings us to, who you avoid giving it to. So if I avoid JAK inhibitors in people that have had previous DVTs, certainly if they're unprovoked. So if I don't have a reason, those are the people I'm most nervous about. And the data bears out, I think, that previous clotting is the thing that predicts future clotting the most. But then there are also some people where you think they've got a whole load of risk factors all stacked up together, and that sometimes makes me a bit nervous as well. I don't know if you have other approaches, but
yeah, that's difficult, because I'm very interested to hear Professor Vidal talk about lupus, because every lupus patient has about 12 risks for VTE before they walk in the door. The serologies, the past history, just the disease itself, the hormonal issues. But in the early studies, it doesn't appear to have been a big issue in lupus.
I mean, of course, I think there was some screening in those studies in the eligibility criteria, wasn't there? So you have to take care when translating into real world use. Yeah, but so far, looks okay. Yeah.
Okay. So that's a good opportunity to move on. So it's a real pleasure to properly introduce Professor Arthur Cavanaugh. Professor Cavanaugh is a professor of medicine, University of California in San Diego, a place that I would love to go and spend some time. I've flown over where you work, but I've never been there. So maybe one day. He's also the director of the Center for Innovative Therapy at USCD, Division of Rheumatology, Allergy and Immunology. And really has an enormous experience of trials, clinical work across a vast amount of rheumatology. And it's a real pleasure to hear your views about treatment of psoriatic arthritis with JAK inhibitors. So thanks, Artie.
Well, thank you very much, and thanks for inviting me to participate. It's great to participate with you all and learn, and it's a super important topic. So very pleased to talk about psoriatic arthritis, and we've had incredible breakthroughs recently in psoriatic arthritis, such that here's a list of the treatment options as you see. And the challenge in a short presentation will be, where do the JAK inhibitors fit in? Right now, as Chris has said, we have one approved also in the US for psoriatic arthritis, that's tofacitinib, but a lot of late phase studies with others, and I'll talk about some of that data. In psoriatic arthritis, and I think it's great to have psoriatic arthritis between RA and lupus, because I think PSA and lupus share the fact that patients can be quite heterogeneous one from the other in terms of the domains of involvement. Everyone, say, has skin psoriasis, I think, and that's a challenge. That how do we identify that 20% of people who have skin psoriasis and are going to go on to develop inflammatory arthritis? But when they do develop inflammatory arthritis, they could have peripheral arthritis, axial disease, enthesitis and dactylitis, of course, skin and nails, and then other manifestations such as IBD and uveitis, particularly anterior uveitis or iritis. And one of the exciting things that we've had and a challenge is that different mechanisms of action can have differential effects on patients with involvement across these different domains. So the requisite JAK slide that I think all of us have several versions of, and it was already covered. I will say, for the specificity, that's a fascinating question, because we just don't know. You can talk about specificity, but as you see, the JAK molecules are mostly homodimers, or even, heterodimers, or even a heterotrimer. So the specificity would really only be for JAK2 downstream of the bone marrow stimulating agents. Otherwise, you can get other effects, and honestly, we don't know. And I think a challenge among the JAK inhibitors, as we have more of them, I know in some countries, like in Japan, they have 5, including pefcitinib available. Are they different in any aspects of efficacy and efficacy across different domains and different diseases? And are they different in any aspect of safety? So what are the data that we have here in the US? Tofacitinib was the first JAKinib in use, and it was much more use, as Professor Edwards said, in rheumatoid arthritis first, but we did get use in the psoriatic arthritis, and this is a study published a couple of years ago. You can see that in the joint responses, the lower dose, the typical 5 milligram twice a day and the 10 milligram twice a day worked well, works great for the peripheral arthritis of psoriatic arthritis. The skin responses were not as robust as some other agents available to us, and there was a decided dose effect, such that the higher dose was definitely better. At this time, the FDA did not grant approval for skin psoriasis, partly on that basis, because when the application went in, they had not yet approved the higher dose for inflammatory bowel disease, which subsequently was approved. We'll come back to the dosing because that's relevant as well. A study just published this year, I think, gets the idea of efficacy across domains, and a JAKinib, tofacitinib, effective in ankylosing spondylitis, which is actually quite exciting. Axial disease or axial PSA is important in a subset of our patients, as we all know, and we have limited availability. We have non-steroidals, and then TNF inhibitors, and now the IL-17 inhibitors, but not much in the way of other choices. Traditional DMARDs have no effect. So these are very exciting data, and we've seen data with the other JAKinibs as well. Filgotinib, this is a study in psoriatic arthritis. This is actually the higher dose of filgotinib, the 200 milligrams a day. And it looked really solid across the domains of disease. Peripheral arthritis also looked pretty solid in skin, enthesitis, et cetera. So the JAKinibs really seem to be agents that can address the various domains of disease. More recent data with upadacitinib, a head-to-head study with adalimumab. In this study, interestingly, the different doses, the lower dose, the 15 milligrams a day, which is the approved dose in many countries, and the higher dose, 30 milligrams a day, seem to be pretty similar with the articular outcomes, but also, if you look in the table at the right, also for the skin outcomes, where they were actually better than what we saw with adalimumab. So again, very exciting data, and also exciting that there was efficacy across the other domains, in this case, enthesitis and dactylitis as well. So we see good efficacy for various aspects of psoriatic arthritis. An agent that's coming up is a newer JAKinib that's being studied in psoriasis and now also in psoriatic arthritis, and that's deucravacitinib, which is a selective TYK2 inhibitor. And TYK2, of course, downstream in particular of IL-12 and 23 signaling, which we know have great importance in psoriasis and psoriatic arthritis. And here you see some very nice results in skin psoriasis and a lot of excitement. Again, are the JAKinibs going to be different in any way, in any aspect of disease, across diseases? And also, what about any differences in safety? So where do the JAKinibs fit in with the other targeted agents that we have? Super exciting times. Here you see different diseases, but I would say I would put the ankylosing spondylitis data with the axial involvement for PSA, and also the IBD data. And you see the JAKinibs are actually, they check a lot of boxes. So they have efficacy across domains, as opposed to, say, some of the other agents where we found that the IL-17 inhibition is actually detrimental potentially in IBD, and the IL-23 and 12/23 don't seem to help the axial involvement in ankylosing spondylitis. So we're learning about the diseases by these specific therapies, and the JAKinibs are actually looking quite good. Of course, the Professor Edwards went over this in great detail. The flip side of the coin is safety. Now, compared to the rheumatoid arthritis, in general, psoriatic arthritis patients a little bit younger tend to have, they certainly have comorbidities, but not as many that predispose them to things like, say, serious infections as do your rheumatoid arthritis patients. We do worry about them nevertheless. We worry about the infections that we talked about. We worry about the MACE events, although there too, we don't see it as much in relation to the disease as you would see in rheumatoid arthritis. Interestingly, in psoriatic arthritis, and I'll say also in ankylosing spondylitis, one of the things that will affect our choice of therapy is laboratory abnormalities, because we have for PSA a number of therapies that don't require laboratory monitoring, the TNF inhibitors, the IL-17 inhibitors, the 23 inhibitors, and 12/23, and even other drugs like apremilast. So it'll be interesting to see how this plays out. We're not super worried about some of the abnormalities, but you do see changes in the blood counts, increases in cholesterol. Some patients have elevated liver functions and a raise in CPK. So these have implications for how I think patients will use these. Finally, about the JAK inhibitors, one thing we've not talked a lot about, though, is the dosing. In all the JAK inhibitors studied so far have been studied at a lower dose, which is proven effective and generally pretty similar to the higher dose. If there's ever a difference, the higher dose has been better. And we've seen the higher dose used, for example, in IBD, where they really like the higher dose. But the safety issues have, I think, tempered that excitement some. And I think that we're considering dosing in the context of the safety issues. So with that, let me wrap it up and open it up for discussion. And thank you all for watching, and thanks for inviting me.
That's fantastic. Thank you very much. That's a really great overview. And I really like the slide, which has all the different mechanisms of action and the different treatments and how that starts to treat us, starts to lead to our understanding of the diseases and how it increases our understanding around that. Okay, so thinking about a clinical question to begin with, I just wondered, where in the sequence of treating someone with psoriatic arthritis do you start a JAK inhibitor? Do you do it right from the beginning? Do you do it after they fail methotrexate, or do you pick different people depending on which domains are involved in their disease?
Yeah, I think here in the US, we're still influenced by what the insurance companies will ask for in terms of sequencing. And because we lack data that says that this person really needs to go further down the algorithm, a lot of people do start on methotrexate. We will use TNF inhibitors very commonly, very early, sometimes first, often maybe after a trial of methotrexate, especially if the insurance says that that's something that should be done. The JAK inhibitors, though, have been entering right there, at that part of the discussion. The advantage is the oral nature of it, which is, of course, better than parenteral. The downside is the laboratory monitoring, but I think they've entered the discussion, and the data I've seen for usage has shown that in psoriatic arthritis, it's ticking up and heading to be a bigger player among the other choices.
Okay, and then thinking about the different domains, the different silos of psoriatic arthritis disease. I mean, you touched on some of this in your presentation. So where do you see it with joints? Pretty good. Skin, tell me how you view it across the domains. What do you think?
Yeah, I think the most recent data, especially with the upadacitinib, were very exciting because the skin looked better than we had expected from earlier studies with the JAK inhibitors. And I think with deucravacitinib, which is again going to be oral, of course, there they have even higher skin responses. So before that, I would have said if someone has a really bad skin, I probably would have migrated to the 17s or the 12/23/23 inhibitors because they have the strongest skin response. But we're seeing really good data across domains for many of the agents we have, it's a challenge. We don't know what's the best agent for the individual person.
Mm-hmm. And then maybe there are a couple of questions coming in about safety that we can talk about in just a moment, but just thinking about, I guess it's related to safety. One of the stories about etanercept in the context of psoriatic arthritis was uveitis, and whether that was the drug or whether it just didn't control the uveitis. Is there any data saying whether JAK inhibitors control the uveitis in the context of people with spondyloarthropathies?
Yeah, as you know, uveitis is super hard to study. You can study the most severe form, panuveitis or posterior. The anterior uveitis that we have in this axial SpA and SpA diseases is so erratic, it's really hard to study. As you said, the suggestion would be that the monoclonal TNF inhibitors, the infliximab, adalimumab, seem to be better than the soluble receptor etanercept, and also better than the IL-17s. We don't have the information for the JAKs yet. And I think as we get more experience, we will see that, because you get that information from registries where you say, well, give me 10,000 people and what is the spontaneous incidence of iritis across different mechanisms.
Yeah, that's difficult, isn't it? Okay, there's a couple of questions, and I think these questions are probably to all of us. So I guess we can all have a view on these things. So the first one, we've touched on some of this. What are your thoughts around oral surveillance's impact on prescribing upadacitinib for RA-PsA? I think those have jumped around, but I guess we've talked about that. Although the data with oral surveillance is for tofacitinib, until we understand it more fully, and first of all, just get all of the data so we can see it all and understand it, there's going to be a little uncertainty around other JAK inhibitors, and we're going to be a little bit cautious. And I think that's what we've all said, and I think that's reasonable. So I think that's probably covered. And then there's one here. Do you see any difference in the safety profile of different JAK inhibitors? I guess that is. It's difficult to see it. For me, it's difficult to see a definite difference. There's some little things that have come out. There's been a suggestion that maybe a bit less zoster with filgotinib. I'm yet to, and I suppose the signals around VTE came out more for baricitinib and more for tofacitinib. But I don't know. Have you, Artie or Ed, do you see any particular differences in the safety profiles?
Although it's not clear, I have recently thought about giving filgotinib to some patients where I felt there were high risks, very elderly patients with a lot of comorbidities, which I think is one of those things like we used to do again with etanercept and the other TNFs. We think, well, then this one may be a little bit safer. I may choose this, but it's not really. I don't think it's not very hard data at the moment.
Okay.
Yeah, I agree. It's a challenge, and like Professor Vitale has said, think back to the TNF inhibitors. How many years did it take? I think most of us would say the monoclonal antibodies have a greater risk than the soluble receptor, but the soluble receptor also has a risk compared to different mechanisms. And it took millions of patients treated before I think we came to that, because thankfully these events are so infrequent. You're looking at study reports of 2 cases versus 4 cases, and one person in either direction, and you're the same. So it's a challenge. I think we will see eventually, though, and we need longer term data with more patients to get that.
Yeah. Okay. Well, I think that's probably. I can't see any more questions coming in there, and that was a really excellent discussion. So, Professor Cavanaugh, thank you very much for the excellent discussion and presentation. So now it's time to move on to properly, although we've been discussing things for a while now, properly introduce Ed Vitale. Ed is Associate Professor and Honorary Consultant in Leeds. Ed has done lots of research around lupus, around rituximab, around ultrasound in relation to musculoskeletal manifestations of lupus, and he's the head of the BILAG group now. So Leeds. Ed, real pleasure to introduce you and to have you speak. So thank you very much.
Thanks very much for that invitation. So, as I've said a few times, we've heard about some programs in RA and psoriatic arthritis that are very advanced. SLE is a field where the clinical trials data is less advanced. The program's not as developed, but I'm instead going to tell you a bit more about sort of why I think this particular class of therapies might offer us something that's maybe more unique compared to what we had before in this disease. So we're moving to a disease now which an obvious thing is the clinical presentations are much more diverse, as we all see in our clinics. It's diverse in terms of the clinical presentations, but it's also diverse in terms of the severity and the response to different therapies. And we can have very severe patients who do extremely well on therapy. And on the contrary, we can have patients who initially might appear relatively mild, but then fail an awful lot of therapies. But the general picture overall is that the existing therapies are not good enough. And so they're not good enough in getting us low disease activity rates or remission rates like we might be able to achieve in rheumatoid arthritis and psoriatic arthritis. And because they're not good enough, that's why we are relying so much more on glucocorticoids, which we're increasingly recognizing are ultimately adding to the long-term problems in this disease. So these sort of issues are exemplified when you look at the kind of therapeutic landscape. So this figure here is a summary of the EULAR guidelines on the different therapies that we might use for mild, moderate, and severe lupus, and color-coded by the grades of evidence. And we have this range of therapies of increasing intensity as we go to more severe disease and more resistant disease. But it's really quite striking that probably even for some of the best therapies we have, you might in a trial see something like a 50% response rate quite commonly. So there are a lot of patients who fail all of the therapies that we have available. And one thing I think that's really striking, if you compare to the kind of like the range of therapies that you've seen in the previous talks in lupus, is that if a patient fails all of this, is it that surprising? Because most of these therapies have relatively similar mechanisms of action. Most of them focus on targeting B cells and T cells, particularly B cells in the circulation. And so if a patient fails one, maybe you might predict that they're going to fail them all. And so, although that's what we've done historically, the more recent sort of mechanistic data are suggesting that innate immunity has a much more important role in lupus than we used to appreciate, and some tissue-specific immunity has a much more important role in lupus. And this is where a new class of therapy, where you where you target signaling, becomes more important. And so my slide on the receptors is a little bit different, and it's different for a reason, because all of the mechanisms that we've seen with JAK inhibitors, like blocking IL-12 and 23, even effects on B cells, they're all relevant to lupus. But there's one thing in particular that does stand out in SLE that people talk about with this class of therapy, and that's their effect on interferons, and type 1 interferons in particular. So this is the signaling that we see with type 1, type 2, and type 3 interferons. And as you can see, they're all JAK-STAT pathways. And we have this recent therapy, anifrolumab, that targets the type 1 interferon receptor, blocking all of these different types of interferon from binding, that appears to be effective in its phase 3 trials. And that is, again, another new mechanism of action. So you can see that we've got a certain, there's a sort of parallel here, that these JAK inhibitors may share some of these benefits as with anifrolumab, but may also add some additional effects. We've got quite several of the agents I'm showing you on here are in trials. You've got ruxolitinib was responsible for some of the early experimental data that I'll show you on the next slide. Baricitinib is the most advanced, has a completed phase 2 study. Filgotinib hasn't met its endpoints in phase 2 trials as yet, although there may be more to see in that direction. And then I've just listed a couple of agents that are in phase 2 trials at the moment, and it's interesting to note this. So these have more of an emphasis on selection for TYK2. So look, this is some of the first evidence that we have of using JAK inhibition in lupus spectrum disease, and we're going not actually to SLE that we treat in our clinics, but actually a rare and monogenic disease called Aicardi-Goutier syndrome. And this is a disease in which there's a single gene defect that causes a difficulty processing nuclear debris, resulting in very high interferon levels. And this presents in childhood, and these children get these lesions that are very similar to lupus, these chilblain lupus-like lesions. They also get lots of neurological features with developmental delay and seizures. And so ruxolitinib, being one of the first JAK inhibitors, was actually available from the hematology world, has been used in this disease and appears to be effective in treating the skin lesions, in treating the interferon signature, and in improving developmental milestones. And so this is interesting that this disease that has a very common is rare, but has a very common pathogenic mechanism with SLE, shows this efficacy. And then the other thing that I think comes out of that, and again, we're looking at the sort of early and experimental literature, is whether there might be something special about particular organs like the skin. we're all taught, as I alluded to at the start, we're all taught to think of lupus as a disease in which circulating hematopoietic immune cells like B cells and T cells are attacking normal tissues. But some recent evidence in lupus is sort of turning this view upside down and emphasizing that the tissues themselves are actually playing a really important role in driving this disease. Not blood immune cells in the tissues, but the actual tissues. So what you're seeing here is a skin biopsy from a patient with SLE, and what you see is actually this diffuse production of interferon kappa, which is being produced by keratinocytes, not by plasmacytoid dendritic cells or any other hematopoietic cells. It's coming from the tissue itself. And then we have case reports like this, again with ruxolitinib, but treating purely cutaneous lesions in chilblain lupus. This is now not a cardiocutaneous, this is an adult with cutaneous lupus who actually was receiving the drug for myelofibrosis, but the cutaneous lupus improved. So now onto the data that we have in more classical adult SLE. So baricitinib, we have a completed phase 2 clinical trial. And so here we're looking at some primary and key secondary evidence. And the primary endpoint of this trial was whether the arthritis and rash that were present at entry resolved as measured by the SLEDAI-2K. And you can see 4 milligram dose there up at the top in red, significantly different from placebo, with the 2 milligram dose not different from placebo. So dosing does appear to be quite important here. I'm sorry, the highlighting, I think I accidentally moved it. It's meant to be on the significant results. So week 24 is the primary endpoint. And so we also have a significant difference at week 24 for SRI-4 and for the physician's global assessment, although not for the SLEDAI-2K. And probably the fact that lupus trials and lupus trial endpoints are a kind of difficult and contentious matter is quite well known, I think. And so it's important to look at these closely. But when you do look at them, you see a somewhat more mixed picture, and maybe not necessarily one that we always expected. So I've highlighted the results where there were significant differences. So we have the SRI-4 result. Now the musculoskeletal data looks good here in many ways. So we have a significant improvement in the tender joint count. We have a significant improvement in this scale for worst joint pain, although not the swollen joint count. But then we don't have the efficacy, as I would have expected to have seen, in the CLASI activity score. And we have a little bit more of a mixed effect on the sort of systemic lupus indices that cover the whole disease, like SLEDAI, BIOLAG, and FLAIR-based indices. So that's that's not an uncommon feature in lupus trials, that you see a mixture of effects on different endpoints. Some of that may be biological, in that the drug really works better for some organs than the other, but some can be due to difficulty in assessing this disease and with the tools that we have. So looking at safety now, so this is something we talked about a little bit in the earlier discussion. So you see some increase in the rates of serious adverse events, so discontinuations and serious adverse events in the baricitinib arms compared to the placebo arms. Not so clear about the difference between the two doses. And it's also, although maybe the numbers here are a bit small, but it's also the issues around DVT and herpes zoster are perhaps a little bit less clear with such small numbers as those. And then lastly, another thing we have here with baricitinib from that phase 2 studies, we have a mechanism of action study led by Thomas Derner in Berlin. And while I emphasized at the start of this talk that a lot of the rationale for using these drugs in lupus has been the fact that they should work on type 1 interferons, actually what this study showed us is that many of the broader immune effects are important. So here we're looking at serum cytokines and seeing reductions in IL-12, P40 and IL-6. And then in a microarray analysis, you can see this, that you've got this whole network of gene expression changes. So to summarize, we've got an unmet need for new therapies in lupus, we need to prevent damage and improve and reduce glucocorticoid exposure. And up to now, I think we've been quite limited in the therapeutic targets that we've tried to develop in lupus, mostly focusing on targeting B cells and T cells. And one thing that has revealed is these are only effective in a subset of patients, and it's not the universal target. So we now appreciate much more about the roles of the innate immune system, type 1 interferons, local cytokine productions in target organs as driving disease. And this is something where the therapies we've used up till now are not very good at hitting these targets. And that's why JAK inhibitors may have a somewhat unique role in treating lupus. But it has to be remembered that trial design can be a bit of a barrier to understanding the efficacy of therapies in SLE, and the path forwards to licensed agents may not be straightforward. Baricitinib is currently in a phase 3 study, and the two other agents I mentioned, the Pfizer and BMS drug, are both in phase 2 studies. So this is going to be an interesting space to watch over the next year or two. So thanks very much for listening.
Thanks, Ed. That was really outstanding talk, and it's a great overview and really thoughtful. It's also always interesting as well when the theory is that it's all the interferons and then it's all the other stuff as well. I just love the way that it leads us to understand it more, and it's not quite how we planned right at the beginning. I was just going to start off by just thinking about some of the trial data you showed. Do you have any sense? It's really early days, isn't it? But any sense of which parts of lupus JAK inhibitors might be best for? You mentioned some of that, but I think to reinforce it.
It's interesting that I would have guessed, and as you would have seen from the sort of case studies that we introduced with, this is going to be great for the skin.
Yeah.
And I would have thought that because when you look at type 1 interferon pathology, it's more linked to the skin, and that's where anifrolumab worked. So that's what I would have guessed. And we actually saw the opposite, really, that the skin data was less clear, but the musculoskeletal data was better. But again, there was an interesting aspect to that, because in most trials, you'd expect to see the difference in swollen joint counts between arms is kind of your clearest and most objective, robust thing that you can measure. But here we kind of saw more of an effect on pain than on swollen joints. And it's fascinating to think why that might be. I don't really know, but it's very relevant to patients, because what a lot of lupus patients will say is everything hurts and no one believes me, and they possibly getting undertreated because they don't tend to get so many swollen joints. And like as you said in the introduction, what imaging studies have shown us is there's a lot more inflammation there than you might appreciate on imaging, and a lot of that inflammation might be in places you didn't appreciate. It's not just synovitis, it's capsules and tendons and things. So that's, although unexpected, it would be quite welcome to have a drug that treats that.
Okay, so just reminding the audience, we're still very happy to take questions. So if you type those into the question box on the bottom toolbar, that would be great, and we'll try and answer those. Did you, when I'm thinking about lupus and those things, I start thinking about interstitial lung disease as well. So this is probably unfair to sort of think about this, but there was a bit of data around ILD, certainly related to rheumatoid and some JAK inhibitors at EULAR, wasn't there? And then I think we were talking last week, and I about this. There's a gain of function, a STAT3 gain of function abnormality that children have that leads to an autoimmune condition with interstitial lung disease. Have you come across any of that, or?
I haven't seen much of the data, but yeah, as you said, these rare diseases, you can learn so much about what therapies do and how a disease works. It's the kind of fascinating observation that would sort of open it up. And perhaps it may not be lupus, actually, where the relevance is so much as some of the other connective tissue diseases.
Okay.
And dermatomyositis, I guess.
Okay. Let me, if I could ask one other thing that's a little bit different about lupus is it gets to the idea of combinations, where in RA and in PSA, we have a lot of studies of just monotherapy or combination therapy with methotrexate. But in lupus, it's not uncommon to add new therapies to the standard of care, which is a lot of immunomodulatory agents. So where do you see the JAKs in the study design and maybe in the clinic as far as monotherapy versus combo therapy?
I mean, study design, they generally have been added to standard of care. Partly, I think this is because people are more cautious about ensuring that the placebo arms of the study in a disease like lupus represent a safe standard of care. So they generally that is what has been done in the study, and it may be one of the reasons why it's difficult to get the studies to work, of course. I think that mechanistically it makes complete sense with a drug like this to combine it with a more conventional drug like azathioprine, for example, that you've got multiple different aspects of, you've got different types of immunity going on in different organs, and you've got, one thing you saw maybe in that baricitinib data is maybe the effects on autoantibody titers aren't as great as something you might see like with something like rituximab or belimumab. So again, that might suggest, okay, there could be a very beneficial synergism here between different mechanisms of action. Yeah.
Okay, so I've got a question for you both. So the first one is a bit philosophical, because it's just about that, we've divided up the talks, haven't we? There's a rheumatoid talk, there's a psoriatic arthritis, there's lupus. In the real world, I sometimes don't know what people have got, and it was more around, is it good to use drugs which have effects across different diseases because we're not always sure? Do JAK inhibitors give us that? And maybe Professor Cavanaugh, maybe you could start that, if that question made sense.
Yes, yeah, absolutely. And I think unconsciously as rheumatologists, we get a lot of comfort if any given drug, the more indications it has, the more comfort that we have. I think that's partly why TNF inhibitors are so well established. They started RA, then went to axial SpA and PSA, and 9 approvals. So we have tremendous comfort with them. And I think we're going to see that with the JAK inhibitors as well. They were brand new when they were just for RA, brand new mechanism, a little bit of a concern, but the more we have efficacy across diseases, the more experience we get. I think it makes us comfortable.
And Ned?
And I think, the other thing it makes me think about, when you've got a mechanism of action that might apply to lots of different diseases, but interestingly, it might not apply to all the patients with each disease. And so then you get a reclassification where you're taking the responder subsets of each disease and you're putting those together and you're saying this is a new group. So I think we saw that with, if you could take things like, with rheumatoid arthritis, we started thinking, when we started using drugs like rituximab, we started thinking, okay, so now seropositive rheumatoid arthritis has got a lot more to do with lupus and ankylosing when we talk about the drug I might use, and seronegative lupus might have something a bit more to do with spondyloarthropathies, and you're suddenly splitting things in a different way. And if you take something like ANA associated diseases, you have a similar sort of concept that, okay, in a lupus, we've got lupus with a high interferon signature and lupus with a low interferon signature. And you can say that about Sjogren's, and you can say it about myositis and scleroderma as well. And if you've got a drug that works on that group, then it might make a lot more sense to just say high interferon, ANA positive disease with a high interferon signature. That's a group, and they're suitable for this therapy. And then you get into basket trials. A big advantage of which is that you don't have to do 6 trials in 6 rare diseases, which are hard to get to work. Just do one.
Yeah. Okay. There's a question coming here about, and this is something we think about occasionally, about combining things. So, taking this up, do you see in the future the option to combine JAK inhibitors with other therapies, anti-TNFs and anti-R17s? So maybe I start, our experience initially with combining biological therapies years ago was that people got more adverse events and people got nervous as a result, and I would remain nervous. So I guess, I look at that and think, theoretically, that sounds like a great idea, but practically, how do I control the risk? And then I start to think, do I adjust the doses so I use a little bit of all 3, and would that be good? And then it starts to get very confusing. I don't know. Artie, do you have any comment about that?
Yeah, I think I still believe that we will find a combination of agents that can be safely used. I think in PSA, one of the things that we're seeing, I think a tremendous amount of anecdotes without actual study, is the combination of a biologic with apremilast, because people have, I think, the sense that apremilast is safe from an immune suppressing standpoint. And so they're dipping their toe in the water. And when you ask people, I think every rheumatologist you ask, they look around, they say, yeah, I have a couple of people on that. The JAK inhibitors, I think that was a different question now with the oral surveillance hanging over us than it was a year ago. I think 2 years ago, we all have been excited. It's like, yeah, let's try this. We want to try this. Now I think we are, we're a little bit more cautious.
Yeah. And Ed, do you have any views on that?
Yeah, so I suppose I raised the prospect that it was something I wanted to do with oral immunosuppressants, and that was done in the trials. But yeah, I share the reservation that, I think the interesting thing, isn't it, with these targeted therapies and cytokine inhibitors, when we saw some safety signals, even if they're rare, that are so totally unexpected. You see some of these really strange things, don't you? One fascinating observation I always found was something like that. Some of the drugs that treated psoriasis, like anti-TNF, were also known to trigger psoriasis in some cases. And so it just shows you how complex the immune system is, and how what we predict we think might happen is often completely wrong.
Okay. I think at that point of uncertainty, that's a really excellent time to admit we don't know everything, and to think about a summary and a close. So if I just summarize, really excellent discussion. Really enjoyed talking to both Professor Cavanaugh and to Professor Vital, and to talk about JAK inhibitors, efficacy and safety in relation to three common groups of diseases, different diseases. And if I summarize, I guess the rheumatoid's furthest along. There's the most trial data, and now there's quite a lot of practical information, and we think they work pretty well. And the safety, there's that little bit hanging there that we're not completely certain, but overall, I think pretty good. Psoriatic arthritis, a bit more clinical experience and more trial data, but not quite as far along that development pathway as rheumatoid. And then all the exciting prospects around lupus, and boy, does lupus need to have some drugs. So for me, I'd like to just thank the speakers. So thank you to you both for contributing. Thank you, CSF, for putting this together. Feedback is really important, everybody. So if you could fill in your feedback form, which is on the screen for you to be able to see, or on one of the bars. So please do that. That's very helpful. And also, if you found this interesting, then on Wednesday, the 4th of August, the next in this series, Professor John Isaacs from Newcastle in the UK will be leading the webinar, and they're going to be talking about JAK selectivity. So that's something we touched on very briefly. So I think good night, everybody. Thanks very much for joining us, and keep safe wherever you are. I'm off to watch the football.
Thanks. Bye.